Thanks for coming, everybody. We're gonna get started. It seems most people have been able to log on. My name is Sarita Wilkins, and I am the Communications Strategist for the National Resource Center for Refugees, Immigrants, and Migrants, and I'm super happy to be here. First, I'm going to give you a little overview about us, and then I'll introduce our panelists who are going to speak to us today about culturally relevant lead poisoning prevention strategies for Afghan newcomer communities. So I work for the National Resource Center for Refugees, Immigrants, and Migrants, or NRC-RIM. We are funded by the CDC and housed at the University of Minnesota. And while we were initially established as part of the nation's COVID-19 response, we now support health departments and community organizations working with refugee, immigrant, and migrant communities that have been disproportionately impacted by health inequities of all kinds, not just COVID-19. We do that by strengthening partnerships between health departments and communities and supporting organizations that work directly with refugees, immigrants, and migrants with the ultimate goal of improving health equity. We support organizations by collecting and disseminating best practices, health communications, and health education, and by offering online training. We also have technical assistance and a few other services. Now, because we work with health departments and CBOs, we're one step removed from the community, and we rely on our core partners to keep us informed of the challenges and successes of both workers and the communities that they serve. Today, we are continuing our COVID-19 work, but on a much smaller scale so that we can focus on the public health needs of new arrival communities. And specifically, we're working on public health initiatives in Afghan communities, but we're also charged with communicating about the health requirements for Ukrainians who arrive through the U4U program. For this presentation, though, we're focusing on our Afghan health portfolio. Now, you'll hear more from me in a little bit, but first I want to introduce you to our speakers. Matt Wilson has served as a health environmental investigator for Seattle-King County Public Health since 2015, with a focus on childhood lead prevention for the past 4 years. Muhammad Ali is the Residential Services Program Manager for Seattle-King County Public Health. He's a dedicated public health professional with a strong focus on understanding the root causes influencing the health of minority communities. And Naveed Hamidi is the Executive Director of the Afghan Health Initiative, where he leads efforts to empower BIPOC and Afghan immigrant communities towards a healthier future. So I hope you'll join me in welcoming our panelists. Mohammed and Matt.
Thank you.
Mohammed, I believe you're, oh, yep.
Thank you. Yeah, thank you. Yeah, welcome. Good morning from King County, Evergreen State. And for those joining us from East Coast or other states, good afternoon to you as well. I am Muhammad Ali, and with me on behalf of our team, Matt, and also Naveed, I want to thank you for joining us this webinar titled Cultural Relevant Lead Poisoning Prevention Strategies for Afghan Newcomers. We are thrilled to share our innovative, culturally competent, and community-led approach that we have used to tackle the lead poisoning issue in our county, especially for the Afghan immigrants, Afghan children. Next, first, let me introduce to you who we are and our organization. Sometimes it's a mouthful of explaining yourself. Where are you coming from? We are coming from hazardous waste management program at Public Health Seattle King County. Hazardous waste is a coalition and public health is part of it. And what we do is basically prevention work, collection, and policy. When it comes to the prevention, we provide education to public, provide technical assistance, incentives to improve the public health and also the environmental quality that we live in. So we want to have our county to be the cleanest and also our community to be the healthiest in the nation and provide a safer alternative and practices to our communities. And also we provide a collection work, providing a convenient collection services at facilities and also mobile services that comes to homes of the eligible community members to King County household and pre-qualified businesses. The ultimate goal, it's not only collecting waste and also doing prevention all the time. We are trying also to have a policy intervention, a systematic change. That systematic change involves this tripod working hand by hand, which is prevention, collection, and policy, which is providing services, creating partnership with the communities and also the stakeholders, and the policy is our ultimate goal. So that is the kind of work we do. Policy, we promote systematic changes in the production, use, and disposal of hazardous material. From the residents, that is the program that I am from, which is the residential service program, Matt and I. And also we have a business groups that work with the businesses, and we have over 60,000 businesses that they deal with. And as residential services, we work with a community of 2.3 million in the county's residents in King County, the most diverse county in the nation. Next, please. Residential service program, we aim to reduce the human and the environmental exposure to residential hazardous material, while we are focusing our efforts on protecting the most impacted and vulnerable communities. Because of resource, we target the most impacted communities in the county. And we do two major goals: exposure reduction and community partnership. Exposure reduction is reducing exposure to household hazardous material through primary. We try to read and do the primary prevention before things get poisoned or get issue. So those are the primary strategies that we do. But that's not what we are talking about and sharing with you today. We also do secondary prevention, which is just catching up and responding to an issue that has been reported to us as a poison, sickened child or family, an issue in the residence. And that is the topic that we're gonna share today with you. And then the community partnership is also another major goal that we have, which is developing, maintaining community partnerships, and strengthening community capacity to identify, that's the key, to identify and manage hazardous material in and around homes. So we can do it alone. We have to partner the stakeholders, in this case, the community partners. And that is one of the examples that we will share with you, how we partnered with the Afghan Health Initiative. What was the need that brought up for our partnership and what has happened. So that is what we are going to share with you today. Next slide, please. So the issue that we are going to discuss today is a lead poisoning issue. Childhood lead poisoning is one of the most preventable non-infectious disease but yet it remains one of the most common problem for our children worldwide. In King County, we are seeing it in the nation, also in US in general, from CDC to other states, and also in King County. We are seeing it, it is a disproportionately impacts refugees and other newcomers children resettled in the United States. In our state, we have a universal testing for children and pregnant women since 2014. And then Afghani children are the highest prevalence of platelet levels, whether it is under 10 or above 10. So they, compared to other immigrants and refugees, they are the highest. And that is the issue as an issue that we will see how we tackle. Next slide, please. So the case management, next. It's a notifiable condition in Washington State. So whenever childhood-led testing is done in the county, it's reported to the state, and next, and then state reports to us, to local health jurisdictions. Any child in King County that is tested, but 5 and up, is reported to us through Washington Disease Registry System. So whenever we receive that calls, that Matt will explain better, then that is how we get started. Though there are a lot of cases, we are still working at 5 and up. And this is the time that I'm reporting is from 2018, before COVID and during COVID. So that is in the context. And I will set up a story about starting from 2018, 19, 2020, where we have been and what have we done? What was the issue that we have been dealing with and how did we overcome? That is what I'm going to present to you. Thank you. Next slide. So in that era of 2018, the county had a 0.5 FTE allocated for this work. While the testing is happening universally, kids are being tested, which is great as an opportunity. And also, and since that time also, the county is also diversifying. There's a lot of newcomers, including refugees, asylees, people are moving in. Our county, we are one of the most diverse. I spoken over 170 languages in the King County. And then in short time, the minority groups, non-whites will be becoming the dominant in less than 20 years. So that is where we are. And then we are having a case loads of children in our cases. And we have a resource issue because 0.5 FTE staffing in 2018. And then we had a tiered system, triaging the cases, and then responding to higher cases only, 10 microgram per deciliter. So that 0.5 FTE can do at least 1 visit a week, 4 visits a month, while you have hundreds and hundreds cases that's awaiting. But what we were good at was sending letters. Any child under 10, we used to send letters, mainly in English, but translated again into a language of the child's family spoken. So, and then, yeah, I think that was the key, as any public health or county health department would do because of resource. You send the letter, you make the phone call, and then whether it's answered or not, and then finally, we move on to the next slide, please. So the opportunities that existed include, first one is, next. So language and cultural barriers that we encountered. It is needless to say that we are diverse, and then refugees are coming from the international world, and then Afghans come and any other immigrants. And then we have someone who is only speaks his primary language, English. And then now this is the time that you experience language issue, whether you are making a phone call or sending a letter, and also having an over the phone interpreter. Even logistics included, even some of the agencies may not have it, the dialects of the Afghanis. Someone might think it is only since you came from Afghani, you might speak the Afghani language, the common one or the official one. But you end up having a Pashto family, and then Dari speaker, and then Farsi. So those are the things that we started dealing with. Cultural issues, including about the gender specific, who's going to be talking, and also the anti-government and all those kind of people histories that brought up with them, and then giving them a call, telling that health department is calling you about your child. And now, and also if you show up in the homes, there's a lot of issues that we dealt that we can talk in the question and answer. And then basically what you deal with is cases lost to follow up because of nobody calls you back, nobody responds to your letter, or people are not responding your voicemail. And then after a long time, then what's happened is even people are losing the phone call was maybe temporary use, and then they moved up. No, they are not answering the phone calls. And then there's a lot of cases lost to follow up. That became a huge EBL case backlogs. Cases were piling up into hundreds. There's a lot of kids needing our support, but there's a logistical, other challenges, structural challenges that we met, and that needed our attention. Next. And the opportunities included, there was a directive from our governor in 2016 that came up that authorizes some funding, Department of Health, to take on dealing with lead poisoning in our state. And then we received some funding for case management reimbursement. So that was an opportunity. In 2018, that motivated us, that supported us, that uplifted us to do and increase our staffing. Next. And then also our program has ways to, we came up a racial equity implementation that targeted to have to lead and look through racial equity lenses in our work, planning, contracting, and tackling the issues about race. Next. And this is the time that our house waste improved and then doubled the FTE from 0.5 to 1 full person, and also more than 1.0 or 1.5 FTE. So sometimes it became a 2 to 3. So that was the opportunities that came up during this time. Next. This is the time that we started looking for stakeholders who can support us. And this is the time that the refugee screening clinic, who is bumping a lot of screening, and then there was a breakdown between the public health clinic that is testing all refugees in our county to our program, which is the case management in the public health. We were not very connected. This is the time that we strengthened and connected the dots and then became a partner. This is the time that we teamed up an environmental health investigator from us, and also a nurse from the clinic, refugee clinic, teamed up to home visits and case investigation. But I'm not presenting that work today. Next. And then we summon all our issues into one thing. What we are looking for, we need to partner with a community partner. And then that's the time that we put together an RFP for a community partner that will help us to do our work better, to engage the community and serve and deal with these cases of hundreds of cases in our caseload. So we put out that RFP. there's a long process that we've gone through, and there was 4 reviewers that reviewed the applicants. There were 2 top candidates that came on the top. Finally, we sat down with them, the reviewers sat down, interviewed, and then because of what we guided us was the racial equity implementation plan, and we looked all angles, and that's how we picked Afghani Health Initiative as a partner to dive in this work with us. And since then, in 2018, 2019, we have enjoyed, and then that's what Naveed and Matt Wilson will share. And then I'm looking forward to receive some of you questions at the end. Thank you, Naveed. Next.
Hello, everyone. Good afternoon and good morning. My name is Naweed Hamidi. I am an immigrant and refugee with lived experience, studied public health, living in South King County, and I am working with Afghan community, public health, and other health systems here in our community, serving Afghan community. Next, please. So in our work with public health and refugee screening clinic, as Matt was and Brother Muhammad was mentioning, and the community partner Afghan Health Initiative, the key person that is leading this efforts and work is our community health advocate, who is directly works with the Afghan community and the public health and the systems that is involved, and make sure that the things that we are doing is culturally, religiously, linguistically appropriate and not sensitive to our community. So the CHA, or community health advocate, is an individual with substantial social connections, and is very known in the community, and speaks the language of the community, and is very trusted. Works between the community members and the public health investigators and workers in the program to make sure that everything logistically goes as smooth as possible. It's a trust builder in our community. There's a lack of trust between the systems, and when it doesn't matter if it's public health or hospitals, doctors, when their child health is in question, the stigma is, or the understanding is that, hey, the parents will get in trouble. So one of the big role of the community health advocate is to make sure that when we talk about their child's health, it's not about investigation, it's just for their children's health sake, and nothing government, law, or law enforcement are not involved at all. On daily basis, what they do when they work with the public health King County, the CHAs build bridge between our community partners and clients. There is a huge gap between the community and the public health and Department of Health and hospitals, and this person makes sure that communicates that in a very sensitive way to both parties, to make sure that there's a sense of trust is built, and also respect is there, and nobody's offending anybody. I was a cultural advisor in Afghanistan working with the U.S. Army, cultural advisor and linguist. It's very crucial in every scenario when you are working with a community or a country or people that their culture is very different to yours. There's always room for error and also room for offending people. Once the offense happens or somebody got offended, the trust is removed. So this person is always there to make sure that people understand each other, and that is how we ensure that the program that we're implementing has a greater and good outcome. And also, this person takes people, the investigators, people from the testing department, people that work for Public Health King County, to people's home. Home is a very sacred place for people, especially in our Afghan community. When male are outside the house, female is always there with the kids. Most of them, they don't speak English. That makes it very challenging for a lot of systems to target these populations, try to do work with them. I'm sure other states have similar programs that they try to reach out to the Afghan community or any other minority community that are very hard to reach. Most of the time, people lock their door. They don't trust the system, so they don't trust the people outside, especially when the mail is not there. But the CHA that we're working with is a female. There's always pre-visit calls that we will go through. They will make sure that they have that conversation with that person and to build that trust. And also they're linguists, so they speak the both languages of the community, which is Dari and Pashto, sometimes different dialects, to interpret and also educate peoples what the lead is, what are the process, and how we are trying to address this issue. Next, please. This is the scope of work of the community health advocate. They usually build reports and provide pre-visit educations to the clients to make sure that they understand what they have to expect from the visit and things to prepare. They always in the phone calls, making phone calls to schedule visits and communicate that both with the client and also to the county to make sure that everything that the client needs to know and also the investigators that is visiting the house is there. In this process, they make sure that the client, which is the person that we want to get their trust, is also educated in terms of how to prepare and calm them and don't panic and be comfortable. They attend the home visits with the investigator from the public health King County when they do testings or visiting their home for whatever reason. They do interpretations and also make sure that everything is culturally appropriate and people are respectful of people's houses. For example, most of the time you have to take off your shoes, and when you go there, you are as much possible respectful as possible. Follow up with the action plans. There are action plans of what to do, how to do it, where to do it, when to do it, and provide additional education for the client. Refer them to the hospitals, clinics, whatever they need to do. And also at this point, there's always a share of resources from our CHA to the persons. It doesn't have to be health, but other resources within the community that exists for them, and they assess their needs. Serve as a human touch point for follow-up questions and connections to additional resources and needs. As I mentioned, they will make sure that talk to the people and see that how they're doing. Most of us as Afghans, when we come here, we isolate ourselves in a one-bedroom, two-bedroom apartment, and it's very hard for us to connect with other people, especially if English is not your you don't speak English, and that's the barrier. It's very hard for you to connect with outside world, with your neighbors, regardless of how diverse that apartment complex is, or people we can relate to, but you cannot communicate. So they make sure that help them build social connections, connect them to the resources and things that happening in the community, and tell them that, hey, this is the number you can call, and maybe this will help you if you have dealing with mental health or whatever. Next, please. Well, as an Afghan myself, when I came here, personal story quickly, that I was assigned through the resettlement agency 2 volunteers that were working with me to show me and settle and resettle in a new country. We saw for cultural shock, whatever reasons, they were helping me out. But the whole community, people that I knew that they came before me, they were saying that these guys are FBI agents, that they're working with you to make sure that you're not a terrorist or you're not a threat to the national security. A lot of other speculations. But now in retrospect, I'm thinking that, hey, that was the mistrust of the community. And I see it every day that there's huge mistrust with the community and also the people that they go to people's houses, especially if they have titles, if they come because of their kids. So families are not aware of lead in our community. They don't know how to put the exposure is, what causes it. And once the system finds out that, or they get tested that their kids have high blood level, they panic that they harmed their kids, and now the CPAs are going to come, the government, the police will come take the kids out. We make sure that we educate them and that take that burden off their shoulder. And there a lot of the time they're unaware of the long-term mental and physical health. There's lack of education among most of our community members. With this program, since we started it, most of our community members now are educated, knows how to prevent it, what causes it, and what are the next steps for them to take, especially if they are in contact with our community health advocate. Next, please. when you start a new program, or you start addressing a challenge within any community, there's always challenges, and there's things needs to consider for a new program. So for us, immediately we understood that families express fear of worrying of unknown and what's happening with their children, and what will this cause? Are they in trouble? Most of the time they talk about that. And there's always hesitations for our community members to be open for us to test their kids or the items in the house, if it's cookware, pressure cookers, or religious items or cultural items in their house that we suspect and the county suspect that will probably causing the high level of lead. There's huge hesitations, and people hold on to those sentimental things that causes those. If it's pressure cooker, or it's a surma or eyeliner or anything that is, we think when we in the past, we tested it and had high level of blood lead in it and contaminants, but they are very hesitant to give that for us, and they are just either scared, and they're also attached to that item. So with educations and leveraging our understanding of how the community works, that makes it easier for us to take the next steps to convince them. Also, as I mentioned, there's always religious reason for the community members to hold on to things. And there's a lot of, I don't know what the word in English is, but it's too much, forget it. Yeah, but most of the time it's religious, but there was a word that I was looking for, that people hold on in Afghan community to certain things. And they think that, okay, if you gave this up, they will be jinxing it, or they'll be bad for them, or it's religiously, or it's just kind of like some kind of out of power there that is connected to this item. So yeah. Next, please. Matt.
Thanks, Naveed. Good morning and afternoon, everyone, wherever you may be logging in from. I am taking this call on the road if the steering wheel wasn't obvious, so please forgive any of the traffic that you might hear speeding by. But anyways, again, my name is Matt Wilson. I am the lead of our childhood-led investigation program. And so I'm just going to give you a little bit more detail as to what our investigation process looks like. Next slide, please. Thanks. And let's go ahead and just, push through all these animations. Almost there. A little bit more. Perfect. Thank you. So in terms of how our team in King County gets notified of a child's blood lead level, so it begins once a healthcare provider orders and completes a test for a child, either a capillary or a venous draw. So that's either a finger prick or collecting blood from the vein. The DOH, or once that lab completes that work, it is then submitted to our Department of Health in the state. It's required that all labs submit such blood work to our DOH. Once it's collected, they have a state-run surveillance tracker for all reportable diseases. And so local health jurisdictions such as ours will use that to be notified of any elevated blood lead levels, which again, as Mohammed referenced, is 5 micrograms per deciliter in the state of Washington. And for us, we get roughly 300 cases in our county. A large proportion of that are Afghan refugees. One reason is that our county is one of the main arrival points for refugee families to settle. And then another is that we actually have a really low test rate for children for blood lead. And that's something that through policy work, another branch of our program that Mohammed had mentioned at the beginning, that we're hoping to to address. In terms of the investigations themselves, they're led by our health environmental investigators, such as myself or one of my colleagues. When we are connecting with an Afghan family, that's when we are connecting with our CHA from Afghan Health Initiative to help us make that initial contact and to, again, schedule any phone or home visit that we might want to have with the family to dive into, what exactly might be the child's blood lead source. Sorry about that. It's a big truck. Next slide, please. So these are just a couple of pictures from some home visits that we've done jointly with Afghan Health Initiative. The photo to the left, it might be upside down. It's of myself using our X-ray fluorescence analyzer, or an XRF. And that is the device that we use to analyze and screen different surfaces and objects, products around the home that we suspect may have lead. So that's our primary method of looking for blood sources. To the right, you can see that one of our previous health investigators, she's sharing some photos of common lead sources that we found, particularly in Afghan families' homes. So she's going over that with mom. And this was actually at a time before we had partnered with Afghan Health Initiative. So we heavily relied on photographs to try to share our education. And that would typically be in tandem with an interpreter over the phone. So again, later on when we would partner with AHI, the dynamic of our home visits would change drastically for the better. Next slide, please. Just another photo here. Me at work using the XRF. In this case, I'm testing cookware. As Mohammed mentioned earlier, aluminum cookware is a common source that we found, particularly in Afghan families' homes, as it's or I should say aluminum pressure cookers. It's a popular kitchen tool to use to prepare meals. And they were used predominantly back in Afghanistan for whatever meals they were prepping. And so once they moved here to the US, they were either donated or sought out cookware that were either the exact replica or something similar to that. But again, through our testing, we found that it actually does, many contain alarming amounts of lead in that. And I'll get into more details the next slide. Thanks. Yeah, let's just push through all of these. So before I get into the cookware, just a quick rundown of, again, the data, the information that we collect and what we share with the family. So again, the XRF is our primary tool to collect most of our data in terms of lead sources, but we'll also collect environmental samples to have analyzed by the lab, particularly things that we can't analyze with our XRF. So that's drinking water. We'll take soil in as well. Dust wipes if a home is built before 1978 and we suspect there could be lead-based paint. So those are a few examples of environmental samples that we'll collect. We will also share some nutritional recommendations to the family for the children, as there's certain foods that would be helpful to expel the lead out of a child's body quicker, as lead will leave the body naturally as long as the lead source or sources are removed. Then it will come out over time. But a healthy diet, one that's particularly high in calcium, iron, vitamin C, that's going to help get it out even faster. So that's what we like to share with the family. It goes a long way. So it's less of an assessment and more of just more education. But if there is a need for nutritional resources or any resources, including developmental screening, we work with AHI to help families get connected to various programs that are available that families are eligible to in our county. And lastly, or after we do our initial investigation, we then just go into a standby mode of sorts, and we just ask the families to make sure they're routinely having their child tested, just so we can make sure that ideally that blood level is dropping. And once it's below our state's BLRV, so that's that 5.0, that's when we'll feel confident that the child has successfully kind of passed their lead exposure. And so at that point, that's when we would close the case in our case management and, move on to the next one. But that said, we're always available to families even afterwards if they have, other concerns that might come up. So, that's something that we'll always provide. Next slide, please. With this slide, it's just to emphasize that from beginning to end, we're trying to stay in communication with the families, with their providers, and with our CHA being a liaison source to make sure that we're all on the same page. So we strongly emphasize that communication and staying just tapping in to get updated on how things are going. It's not a perfect process, but we're working on it. It's something that with everything else, we just get together and we learn how we might be able to better connect with some families that maybe after we initially communicated with them, for their own reasons, they're harder to reach afterwards. Next slide. So as we mentioned, aluminum cookware is a significant lead source that we found in families' homes that they might have been donated to them or they purchased online. And so the picture to the left is of a traditional pressure cooker that was made in Afghanistan or Pakistan or around that region. And we found that most, if not all of those pressure cookers, because of the method of how they were manufactured, they contain unfortunate amounts of lead in it. And so we were able to acquire public health fundings to purchase a large swath of safer alternatives that a research team that we're partnered with was able to confirm has no concerning amounts of lead in it and would be safe to cook with. And so now we offer those alternatives, both this traditional-esque kind of style megafessa and then a electronic Instapot, of which we've learned that many families are interested in. They like the convenience of just kind of set it and forget it. So with that, we've been really just lucky to be able to offer these replacement cookwares for whenever we do find that family has a leaded cookware. Not sure how long this program, this exchange will go on to. That's all depends on funds, but at least for now, it's a well-received service, resource, and yeah, we're happy to keep that up. Next slide. Just a picture of an exchange like just happening in the moment. So that was a traditional cooker that what a family was using, and they were given a replacement, pretty sure a Magnafessa in this case. So yeah, just a really successful program thus far. Next slide. All right, back to you, Mohammed.
Thank you, Matt. Thank you, Matt. So eventually, after putting all those efforts from AHI and public health partnerships, it has been noticed nationwide, and also to G7. Our research guru, Dr. Steve Whitaker, presented many places in the nation, in the conferences, and also NAMA, which is the North American, NAMA, it is a hazardous material organization, awarded us as a 2013 prestigious award as agents of change. This partnership has been also noticed, not only this is a kind of a get together between us. Matt was not there that day, he couldn't make it, but you could see it. Some of the research team, Steve Whitaker is from the far left, it's Aisha and intern, and the other smiley person, that's me, Steve Whitaker, and then Nilo, the centerpiece. Nilo is the community health advocate. Let me introduce to you. Nilo is the center, and she is holding the award itself. She is the community health advocate that we used that has made this drastic change for work. I was presenting you a caseload in the hundreds, and now we went down to 0, even looking for cases as they come in. So that is the partnership, and you can see it, Riza, Navib, and Ariana. Those are the change makers. Acknowledgement. This work has not been possible without the support of research team and our other exceptional teams that are not here today with us, including Sharon Cohen, who is the person who coined this issue, led in cookware from the homes of the Afghani families. And then the rest of AHI team who are not here, like Nilo, and the rest of the team who have contributed to this work. And then the wonderful team members led on toxics from our team, public health, and many who are not mentioned here. So these collaborative efforts, expertise, and commitment have been instrumental in achieving the success of this project. Thank you.
Thank you so much, Mohammed. I'm just going to go to the next slide. One thing that all of our speakers talked about is the importance of education with the Afghan families that they're working with. So I'm going to go over a few tools that organizations can use that will support their own lead prevention and testing and treatment efforts. And so we've seen the most innovative practices coming from with health departments and community-based organizations like Seattle County and AHI partner on solutions. And so from your partners, you can learn not only about the topics that are of most interest and concerns, but formats that'll work best and how you should disseminate your materials. And we work closely with our partners like the Afghan Health Initiative or the International Rescue Committee and others to make sure our health education materials are as relevant as possible. We have an extremely rigorous translation process that goes above and beyond industry standards. So after translation, we also work with cultural validators from the community to confirm the language that we use. And they make sure that our translations are not only accurate, but culturally appropriate. And our cultural validation extends to the design of our materials as well. The photos we use, the way our materials look, and how we incorporate Afghan cultural references are all the result of conversations with our partners. These are a few of the key messages that we have about lead poisoning that incorporate Afghan cultural references. So we talk about the traditional use of surma on children. We talk about cooking Afghan meals in safe cookware and following the Afghan tradition of removing one's shoes before entering a home. And all of these are cultural references that do contribute to lead poisoning prevention. The health education materials we have for lead poisoning cover both prevention as well as testing and treatment. And we also have a number of different formats. And so we create fact sheets and social media assets that are translated and customizable. We have audio PSAs that can be sent on WhatsApp or other messaging app, which is super helpful for a lot of immigrant communities. And then we have video PSAs that we post to YouTube that any organization can repost to their own accounts or share however makes sense for them. From our partners, we learned that many Afghan people rely on an oral tradition. So even among people who read, many prefer not to receive information this way. So each of our fact sheets for our Afghan health portfolio has a QR code that links to a video of someone reading the fact sheet aloud to them. And this way we can meet the needs of people who prefer to read as well as those who have more oral traditions. And we want anyone to be able to customize our materials, even if they don't have design software or a communications or marketing department. So if you can use Microsoft Word or PowerPoint, you can use our templates. We created these drag and drop templates in Google Slides and in Canva. So if you want to remove our logo, put your own logo on, or swap out the photo, you can do that, just drag and drop. And in addition to lead poisoning, we also have some materials on summer safety, on mental health and stress, respiratory illnesses, wildfire smoke, and then we're working on one on women's health. And if you liked this webinar, we'll get to questions in just a minute, but I just also want to pitch the Center of Excellence for Newcomer Health also has a lead webinar coming up on November 6th that talks about lead screening among pregnant and lactating mothers from refugee and immigrant communities. So definitely check that out. That's all I had for you today, but I see the chat has been pretty active, so we can get to some questions here. I saw one that was answered earlier, but maybe you all can talk about it anyway. Somebody had asked, how do you recruit or identify individuals who work in the community health advocate role? Naveed had talked about that, and I think Mohammed answered that. So either of you have any insight on that you could offer?
If I go quick, so from public health perspective, I think we needed a scope of work of a community health advocate. Who that person would be, language, gender also, that's also very important, gender specific. And it was very hard to go through the, but it was, luckily we got it, a female English speaker who speaks most of the Afghani language, Dari, Pashto, Farsi. And then that's who identified from the community partner. We wanted to get an ideal person, and then the community partner provided to us. Naveed.
I'll invite all of our speakers to turn your cameras on. Naveed, did you have anything to add about recruiting community health advocates? Okay, I'll keep going. There's a question also in the chat. Have you found an alternative to SIRMA that's acceptable to the Afghan community? And what we say in our materials is that they should seek out cosmetics from American or European brands, but I'm curious if anyone on any of our speakers have experience with that. Do you recommend specific brands or anything like that that could be an alternative for folks that's safer?
Yeah, I could take that on. We don't have any specific brand yet that we've identified that's suitable. A large challenge that we find is that, SIRMA, it comes, there's something about like it comes out of these pouches. It's produced in a sort of way that to buy like a Maybelline pencil is just, there's a disconnect there. So, but fortunately, Mohammed is actually leading some work to that's partnered with AHI to help identify what might be a suitable alternative through mass testing of products. And then I think it would follow up with interviews, conversations with community to see, what might be suitable. So we're still in progress of trying to find one as well. It's a tough one for sure.
Thank you. Just to add one more sentence of that. Yes, thank you, Matt. we are working on it, and it's happening. We conducted so far 30 homes surveys on traditional eyeliner. Kol, Kajal, Surma, you name it. There's a lot of interchangeable names that came up, and it is our second topic that we are going to work on it, still working on it. And then we identified some safe alternative from the community recommended. We took a lab. There's a lot of qualitative and quantitative data analysis that's happening. And we got a November community forum. Hopefully next year, we will be seeing a better answer that could tell us about if we have something or not.
It's good to know that that's something that you're working on. Naveed, do you have anything to add, or should we go to the next question?
Next question, please.
Okay. So one question that I had, visiting somebody's home, particularly to discuss a health concern, can be very personal. Naveed, I think you said in Afghan communities specifically, it can feel it's like kind of sacred to enter somebody's home. So what steps did you all take to help gain community trust?
I think for our community, it's just that trust of first initial conversations that we have with the community members, explaining the process in a way that is very calming. And also it really helps that if somebody speaks the language and knows the family, build that relationship with them, that brings a sense of calmness. So communication and educating them and giving them the more details about what's happening. And this is to take that fear factor out of that conversations or that setting, to make sure that they know that this is not like any investigation. It's not like that's something bad you did. It's something that is happening. It's not only you, but it's just the whole Afghan community. And from that education piece, that comfort come and trust is built.
It sounds like, and correct me if I'm wrong, but it sounds like it's really about reaffirming a cultural value around family, about protecting and valuing children, and like how can you listen to that and then reflect that back to them. So that, yeah, definitely very important. Mohammed or Matt, did you have anything to add?
Matt.
No, nothing to add there. That was good.
One of the questions in the chat, it says, when educating people about diets, are there any cultural food dishes that you should recommend to families? As in, addition, obviously for safety reasons or for healing reasons, if somebody has elevated blood levels, but also just as a way to connect and build rapport with the families. Like, what food would you recommend that supports sort of health?
Yeah, that's a great question. That's actually something we are just recently starting to ask ourselves, like how we can have more culturally relevant diet recommendations. We largely just use what the EPA offers, which is helpful, but yeah, we're looking for something that is going to be more familiar to families, something that's more in kind of like their circle of common foods, so that's something we're thinking about. So I love the question, but we don't have anything yet, but I maybe Naveed might have some ideas, given the foods that we recommend and what might kind of be that kind of cousin to it, or whatever you'd want to say, hey, if you like this, or if you recommend this, try this. So I don't know if you might have something with you.
Yeah, for sure. So food is a big part of our culture, and it's very hard to give up certain type of food. We never try to do that. We just try to educate them in terms of like what are some alternative ingredients that will help, and also eating more vegetables, greens. It's very hard for our community to eat vegetables. It's even if they eat vegetables, very different the way they cook it or the way they consume it. So it's never a replacement, but it's just more recommendation of food that are rich in both macro and micronutrients. And they don't know that. A lot of the time, that's lack of education and lack of understanding of what food will have more, for example, iron. And the community health worker will present those for them to make sure that you have more iron in your blood, kids' blood, and eat more apples. And fruit is not that big in the community. It's just food and bread, and a lot of oil is involved, and salt is involved, deep frying, all of those. But in this process, we tell them that, hey, if you cook this meal, this could be a good add-on to get more nutritious food.
Thank you so much, Matt and Naveed. That's all the time we have for today, but thank you to everyone for coming. You'll get an email from me in the next couple of days that has a link to the slides and the recording and links to all the resources we shared. So thank you so much and have a good day.
Thank you very much.
You too. Thanks.
Thank you, everyone.
Bye-bye. Thank you.